just don't even say anything about some things, so.
But I need to get back on there with that and see if they have got it. If they haven't, then I'm gonna.
And there's a place where it talks about being able to do votes in writing and things like that, but
Yeah, well, we can't do
I think that's against the writing laws.
resolve this, you know.
Dug in.
Yeah.
Great, heard some threat. Thanks for your help.
Yeah, they said,
We can do business on the better.
That's what my thought is, we have it in our bylaws, but I think it's in violation. No, I think you're right on that.
In writing you can't, whatever.
Well, yeah, they've used it for years. You know, it's gonna precipitate some kind of.
Oh, better have some.
Well,
Yeah, I know.
Public needs to be able to hear both sides of the conversation.
you guys are.
yeah, we're still working on it.
Anybody who voted by phone in has to have been privy to the entire conversation. They just can't phone in for the vote, they have to be involved in the entire discussion.
Tied up
So,
until
yeah.
5 o'clock tonight.
And as far as conference calling and stuff like that, I didn't, that's why I think that if we're gonna do conference call type of votes, we have to notify the public, because we have to give them access to be able to hear to those conference calls.
So that's why I told Cindy.
Yeah,
That's why I really tried to not.
Just to get a.
Yeah, we couldn't just do that. We can only do it if there is an actual meeting.
Trying to fatten me up to the kill here.
That's what it is.
And maybe one or two
Yeah, that's great.
participants in that meeting
One of these big,
are on the phone.
big pieces
But
of
the public has to be able to hear the whole thing, and the participant has to be able to hear everything the public has to say.
Well, did you have any success with your hunting?
Only works if it's equivalent.
You start the year. Well, that sure is different. I got in the car and came home.
Well, that's a true brand. You enjoy the experience being out.
I think, thank you. Yeah, I think my
Okay.
cojones fell off.
If everyone can kind of find their seats, we're running a little bit late, I wanna get started here. We have a very full agenda today. We do have a quorum. I'd like to call this meeting to order. It is 1:11. And our first item of business would be any public comment.
How you coming on CEO?
We have an interim, and I was gonna, after public, we were going to introduce him, so.
Have you all met the new CEO at the health center?
Yes, we have.
I really like it.
She's
Very impressed.
She's great.
Yep.
I just have a quick, I'm Lori Johnson, Mineral County Commissioner. I was just, because we are a ex officio member of the board,
Dwayne is, yeah.
well, he's kind of passed it on.
Oh, okay. So
But
are you-
anyway.
So you are now?
Well,
Okay.
one of the two of us, but anyway, if we could be, I guess, more informed of meeting changes, because I came last Thursday expecting a board meeting and there wasn't any, and so, you know, nobody had let us know that the meeting had been changed.
Okay, it's been posted for a couple of weeks, but.
Well, I mean, it wasn't even down in the courthouse, there was no notice on board down there,
Is
so.
that one of the, let's put one on the.
Well, I mean, even an email, just.
Lori, can I, and kind of fallen away from this, but I'm with Dwayne for a while, and I'll add you to my email list when we're, with board, all the, you know, when board packets and all of that stuff goes out, because you need to be part of that, even though you're not a voting member, you're still an ex officio as far as all the discussion and everything that happens too, so
Yeah.
I'll make sure you get on my mailing list
Okay.
when things go
Okay.
out to the board like that.
And, you know, like the agenda and stuff, so we
Absolutely.
kinda know ahead of time, and I wanna thank you so much for sending me the information on how the boards, you know, that was very helpful. And,
Was that helpful?
Yep, and and I appreciate you doing that.
And if it would be helpful, if the commissioners would like, if there's questions about that, I'll sit down, and I'd like to have an open line of communication.
Yep, yep, that would be great, so. But anyway, just
Yeah,
if we could keep us a little bit more informed
Okay.
of the kind of goings on the board, I'd really appreciate it. Thank
Okay,
you.
I'll do that one.
I just have two more things. Will you be getting a look at the audit that's happening today for the innovation grant?
No, but I understand that there's more information. I haven't seen the specifics, but we're trying to work it out where we can.
Yeah, because they're supposed to be doing it today.
I don't know about
I
that.
think they're talking about just it's a routine audit, the
Oh, that,
annual
I don't know,
audit for
I
the
don't know
clinic,
about that.
which would include the innovation. It's
Yeah.
not any specific thing.
Leona, I don't know anything about that.
Okay.
Well, the hospital auditors are around too.
Yeah,
Oh,
it's
are
the
they
same.
here too?
Yeah.
Same group.
It's just an annual audit.
Right, a routine financial audit that is done every year, right?
Right.
That most organizations do.
Right.
I don't think it's it's not specific for innovations.
Well, when I went to their meeting last Thursday, they talked about it like it was, that they were gonna reconcile, their clinic with the innovation to see what was what.
Yeah, but we were,
Are you,
setting up a particular date, because that meeting date has not even been, we're gonna do it sometime this
so
week.
are you asking
We
about,
haven't got together yet.
You're talking about the figures on the grant, and the question.
the disallowed amounts, is that what you're asking
Yes.
about?
Oh, okay, yeah, that's.
That meeting hasn't been scheduled yet?
Yeah, that's not what the auditors are there about today at all.
That's what they said, because I've got it here in my notes. Anyway,
That's what's going to happen, but it hasn't been scheduled yet, is my understanding.
well, that was what Bill was saying, it was scheduled for the 29th. That's why I wrote it down. Anyway, the clinic has moved their public comments back to the end. I sure wish you guys would do it too. It's kind of dumb to be sitting here and you have your meeting and then I have all the questions and the public comments at the beginning of the meeting.
We can consider that.
I sit on a board in Helena, the Montana Facility Finance Authority Board. I've sat on that for 9 years. We have a public comment period. Also on a couple of hospital district boards that I've sat on in the past. And I've never seen the public comment period be at the end of the meeting ever. Always at the beginning. I don't know if it's required that way or not.
It's
You have to,
It's not.
you know, I guess you could schedule
Yeah.
it, you know,
I guess we could
It's
put it
your
wherever
option.
we want.
yeah.
The intention was so that, well, for a while, a lot of the public comment we had and people would come and talk to us didn't want to stay through the entire meeting. They just wanted to say their piece and leave. And so we didn't want to
Right.
make them wait for the whole meeting to be able to do that. That was one reason we did that. The other reason was, if we have it at the end, if there's any comment on some of the things that we're gonna vote on, the decision's already been made at that point.
I
And
think that's the-
it kind of makes it moot at that point to have public comment if the decision's already made. We wanted to have that prior to the decision.
But if you discuss something we want to ask about during your meeting, we've got to wait another month to ask it.
Have we ever had, situations where there was you kind of split, there's 5 minutes for initial comment, people want to make it and leave, and then there's 5 minutes at the end for people who want to ask questions. So, it's probably out of protocol, but it's practical.
I don't know. That's one way we
We
could
could
approach it.
consider that.
Yeah. I don't think there's not a standard way that you have to do it.
Yeah.
You just need to have it. So whether we split it, that's a good thought. That's a good thought. Okay.
What does the commissioners do?
We just kind of fit it in whenever there's, most of the time we have it from like 11:30 to 12 or 11 to 12, unless we've already got something scheduled in that time slot. But we usually try to have it, if we have something scheduled that part, then we'll do it like after lunch, but it's always towards the end of the agenda.
I can tell you, town council always does it at the beginning, so.
Oh, yeah. We usually have it towards the end, just, in case somebody has a comment or whatever on something and we've always given them a chance, say if it is, something we're discussing on the agenda, if they have a question or something, they'll ask it then too, so we just kind of leave it open.
All right. Well, can we move on then? I would like to introduce our new interim CEO. This is Larry Putnam, and you have 5 minutes. You could just tell everyone a little bit about yourself.
Yeah.
And what you bring in and to our organization.
I'll try to keep it shorter than I did 2 weeks ago, yesterday when I met with the board, and the discussion kind of drifted, and it wasn't a very focused discussion at all. I'm surprised they called me back and asked me to come back after that performance. But yeah, I'm Larry Putnam. And I'm one of the people that I worked with at one of the interim CEO assignments that I've done previously. I kind of nicknamed me the bald-headed bean counter, because I don't have much hair up on top and haven't had since I was 21 years old. My hair has been gone. I used to have a comb over, and my wife hated it and my kids hated it, and so I finally shaved that off a long time ago. So my nickname of bald-headed bean counter is appropriate. I haven't counted beans, and that's probably not a very good term to use with CPAs like Cliff. Cliff enjoys those numbers, and I have not directly dealt with numbers in a hospital for a long, long time. But I'm an old Montanan. I've been around a long time. My great-great-grandfather came to Virginia City in 1862, actually, and I've been hanging around Montana ever since. My grandparents and great-grandparents have been hanging around Montana for a real long time. My wife and I grew up in Billings. Spent some time in the military a long time ago. Came back to Montana, got a master's degree in business from the University of Montana long time ago. Long time ago. And went to work in Helena the first time that we lived in Helena for about 10 years. Half of that time was at Boulder River School and Hospital. They had 1,000 employees at that point and 900 residents. I always forget which is which, either 900 employees or 900 residents. I can't remember. So that's my only real experience with a very large healthcare facility. I really like the small, and have worked most of the rest of my career in healthcare has been, all my career in healthcare has been real small critical access hospitals, real small critical access hospitals like Superior. 2 years in White Sulphur Springs as the CEO, 5 years in Monticello, Utah. I went down to Monticello, Utah. I worked for Lutheran Health Systems in a small community down there for 5 years. I kind of did things on 5-year increments until I came back to Montana 20-some years ago now, and was in Malta, Montana. If any of you know where Malta is, do you know where Malta is? Up on the High Line, 200 miles north of Billings, almost straight north of Billings. And was there, I figured that I would be there, my wife and I figured that I would be there for 5 years, and then I would move on to another hospital. But we really liked Malta. It's a great community. worked with that community. I was there for almost 14 years as the CEO. We built a new hospital like you were trying to build in Superior here while I was there. Worked with the community. That was a great project. Really enjoyed that project. Also, we bought the nursing home, which was owned for a long time, many years. It had been owned by Evangelical Lutheran Good Samaritan Society, another nonprofit corporation from Sioux Falls, South Dakota, actually. It took me a long time, and the community a long time. We finally bought the nursing home and created an integrated system like you had here with a clinic, a hospital, long-term care, and most importantly, probably an ER. It's a very important service, for the community. About the same size as financially as the operation here, about $6-7 million hospital. You're at about $6.5 million, I think. Is that correct, Cliff and John? I tried to retire 6 years ago. Moved to Helena, and have been the way I've expressed it to the board and the leadership team here is that that was a pretty unsuccessful effort. The phone keeps ringing. I have done, this will be my 5th interim CEO assignment in starting my 7th year, and in between there, I did a 2-year project, almost a 2-year project for the Hospital Association. Was the project director for a federal grant that was developing a new integrated approach to, paying for and managing frontier-sized hospitals, real small frontier-sized community critical access hospitals. And I don't know if I said it, but we moved to Helena, back to Helena. We have kids and grandkids there 6 years ago. And I commute back and forth on these interim assignments. I've done interim assignments in Big Timber, Montana, Lovell, Wyoming, Jordan, Montana, for 4 months. Last summer I did a 4-month interim CEO assignment in Livingston, for Livingston Healthcare. That's the largest hospital I've ever been the CEO of, is Livingston. And now the Superior. So my world is just real small critical access hospitals, clinics. Also, I'm not an expert in FQHCs at all. I was really thrilled, to make contact with Cindy yesterday, Cindy Sturgar, Sturger, do I have it right? Sturgar, okay, sorry about that. And I hope, Cindy and I had lunch yesterday, and I think it's really a good matchup. It's just absolutely critical moving forward that she and I, on an interim basis, work hand in glove. It's just got to be that way, or we will not be successful here. I'm looking forward to the interim assignment very much. Just in the short time I've been here, you have an outstanding team, leadership team. You have some really, really good people. You're fortunate. A lot of communities this size don't even come close to having, the leadership group that you have here. The medical staff is solid. You have good physicians here. You just need to use them. Don't get all hung up on quality issues with those physicians. They are, I'm sure, delivering high quality care. We just need to demonstrate that to you a little bit, maybe prove that to you with some of the data and the statistics. But if you want to help, this hospital grow and turn around and move forward, use the facility. That's one of the things that you can do. And I would encourage you to do that if you're in the service area. It's real important. Critical access hospitals, integrated healthcare systems like you have here are just absolutely critical, for economic development moving forward. My approach to all of the interim assignments that I've done is always, the board and the leadership team are going to probably get real sick of me hearing this, because this is my theme, is to get what happens usually before the interim shows up is you know, the board's off in this direction, the physicians are off in this direction, and there's a CMMI grant, you know, off in this direction. And, you know, a health center, a bunch of folks over here, and the county commissioners are way over here, and nobody's talking, you know, nobody's communicating, you know, and, you know, my goal is to just get everybody back on the same page. And we all agree that the history is history. We put all that stuff behind us, and, you know, I'm not a part of the history anyway, neither is Cindy. And, you know, we're just excited. Both of us are very excited. I did have lunch with her yesterday, and, you know, we're both real excited to be here and to work with the community and to keep the community informed and all of the groups informed and work with you and move the organization along. And, you know, it's a beautiful area of the state. You know, great opportunity, I think, for the community to just really roll and kind of work your way out of some of this history stuff that we've seen, you know, over the last year or so. Well, my time is up. I better sit down.
Thanks, Larry.
Yeah.
So, I would
Standard
just encourage
speech number
everyone
422.
Just encourage everyone to spend some time, get to know Larry a little bit.
Yeah, please do.
Thank you. Now, I'd like to turn the time over to Kelly Casey, who's here from Yellowstone. He has a presentation for us.
I'll get out of your way here so they can see. Get my ball head out of the way.
Kelly bought lunch today too, by the way.
Thank you.
Thank you much. Thank you.
You haven't seen the bill yet.
Do we need to get lights?
This for a moment. Thank you. Sit over here.
Well, thank you all for having me here today. My name is Kelly Casey, as mentioned. I'm the head of marketing and sales for Yellowstone Insurance Exchange. We're your professional and general liability insurance providers. This year marks Yellowstone's 10th anniversary, and to help celebrate it, we're doing Appreciation Day presentations at each of our hospitals, and we're hosting lunches or dinners or whatever each board really requests, and just giving a quick Yellowstone update and answering any questions that any of you might have on the company. So, just a pretty quick agenda here for today. Just take you through the brief history of Yellowstone, touch a little bit on Mineral Community Hospital in general, and then bring you up to speed with some programs we have going today with Yellowstone. So, for the history of Yellowstone, it started in 2003. In 2003, many commercial carriers exited the professional and general liability insurance marketplace. The market turned hard, and prices increased drastically for the market. So what had happened was about 6-8 CEOs got together and said there's got to be a better way to do this. And so they started Yellowstone to create stability in the marketplace for critical access hospitals in the state. It started with 15 charter member hospitals. In 2003, 13 hospitals initially joined, and then in 2004, 2 more joined, all from Montana, Idaho, and Wyoming. And then, since then, we've actually expanded to New Mexico. We have 2 members there now, and we're looking at expanding into North Dakota as well. On the right side there, you'll see the key success factors. Just remembering the insurance cycles of the past. Remembering what the insurance market does. It goes up and it goes down. It follows a hard and soft market cycle, and premiums fluctuate pretty drastically. There's a long-term commitment with Yellowstone. Just remembering that each hospital is in it for the long term. The stable and slow growth of the company. They don't have me out there beating the doors down of every hospital trying to grow the company. at a risky and fast rate. We want maybe 1-2 hospitals a year, and only really the good, safer hospitals for the program to protect the group. And then not to drift from our core competencies, really staying true to why Yellowstone was created, not changing anything or any of the services that we've provided or anything that makes us different or better than the normal commercial carriers from the past. On the next slide, just a little bit on Mineral Community Hospital. You joined Yellowstone on September 1st, 2004. And then with the claims management, the one thing that makes Yellowstone really different than most commercial carriers is we won't settle a claim without your permission. It's your hospital, or it's your company. Your hospital joined the company and you became an owner, so if a claim comes in that doesn't have any merit and you want to fight it, that's what we're here for. We listen to you guys. For the claims section down there, the total claims with Yellowstone, that data was taken from January of 2013, 2 closed, 1 open, with total claims paid of $32,000. Since then, the 1 open claim has been closed, and the total claims paid is just around $70,000 total now. Just some financial updates on Yellowstone here. The capital contribution return. In total, Yellowstone's returned just over $5.5 million to the membership in capital contributions. And then Mineral Community Hospital's capital contribution return was $106,000. In 2009, the Subscribers Advisory Committee, or the Board of Directors of Yellowstone, decided to start paying back the capital 3 years ahead of schedule. And so they paid 33% per year for 3 years, starting in 2009 until it was fully repaid. And then on the right side there, you'll see the subscriber savings allocations. What that is it's a fancy term for dividends. Yellowstone's total dividend return since 2003 is just over $5 million. Your hospital in particular's dividend account is totaled at $97,549.14. And then in 2012, they did a direct release from your subscriber savings account and paid out $4,600 to your facility. So the total amount returned in capital and in dividends is just over $200,000. Okay, next slide here. Like I said, the risk management piece of Yellowstone, that's really what differentiates us from other providers. Kirsten Locke and the nursing staff have been doing an absolute great job just staying involved with the program, the education opportunities. Yellowstone provides action plans for each hospital in the company. It's specifically made for each member. 3 to 6 visits per year from our risk management teams. The Yellowstone event system, we provide an online incident tracking software, a video training library, and a credentialing system to our membership at no additional charge. And then for the directors and officers, it's really imperative that the board of directors at each member of Yellowstone and the officers at each hospital stay involved in Yellowstone, ask questions, come to our meetings. It's really key to Yellowstone's long-term success and keeping everybody updated on the program. So, but Cliff and John have been doing a great job, and so have all of you. Yellowstone today, so about a year and a half ago, we added 2 additional products in addition to the professional and general liability insurance. We've added the medical billing, errors and omissions coverage, and the privacy and security coverage, which is a data hacking coverage, basically. We've added those 2 products to the membership company-wide at no additional charge. Any new members, they have to come in, they have to be members for 5 years to get those at no charge. So if a new member comes, they actually have to pay for those coverages. And that also starting this year, we started planning, looking for it to go live next year, is the new Directors and Officers Liability Program. We've seen, so far in the last year and a half, D&O premiums really start to skyrocket. A few of our members seen a 30% increase, and they didn't have any claims on their D&O policy. So Yellowstone is looking at starting their own program for the D&O to be able to offer an actual Yellowstone written policy to the membership. As it states there, out of the 2012 net income, $100,000 was used to distribute to all members of Yellowstone, the 24 hospitals, to use for a D&O premium to put towards that and to alleviate the potential increases that we've been seeing. So that's going to be in place going forward, the $100,000, until we have the Yellowstone program actually set up, and then that $100,000 may increase or may decrease slightly, just depending on the costs associated with the programs. And then lastly there, Mineral Community Hospital's allocation for out of the $100,000 was $1,548.13 to put towards that premium. So. And then just a quick financial update on Yellowstone. The 2012 net income was $1.4 million. It was the highest income, our net income to date for Yellowstone, and all of that was distributed to the membership as dividends. That compared to 2011's net income of $451,000. Total assets of 2012 were $25.4 million, compared to 2011's assets of $25.9 million. And then the subscribers' equity piece, that's just the total dividend shares of all the members in Yellowstone. The $5.58 million for 2012. Compared to the 2011 number of 4.241. So the difference between those two numbers is just that net income of $1.4 million there. So, and then on the right there, the 2013 and beyond. As mentioned earlier, we released a portion of the dividend accounts to the membership, and we created a new program called Spectrum, which gives the membership a customizable option in how they actually receive their dividends. They can either take it in cash, use it as a premium credit going forward, or they can choose to recontribute that portion, leaving it in their account, and Yellowstone will match it with a predetermined amount that has been set by the Subscribers Advisory Committee at the start of each year. And then lastly there, the shareholders. When Yellowstone started, it only offered A-share members. It was 100% capital contribution of your first year's premium. Since then, about 6 years into the program, they started to offer two different types of shares, A shares and B shares. A shares was still the 100%. The cheaper way to join was to offer a B share to only allow, or to only require a 50% capital contribution. So it makes it cheaper to join, but at the same time, the B shares only get 50% of their calculated dividend per year. And then just recently, last year, the board voted to not allow any more A-share members into the program. They felt that the members that took all the risk at the beginning when starting Yellowstone, they're starting to see such a high return, they don't think it would be fair for a new hospital to come along and pay the capital and get the same return. So I'm not allowed to offer A-shares to any new hospitals anymore, only B-shares, and the A-share slots are full going forward. So, and that's basically it. As mentioned, this is just to say thank you to you guys and thank you to the membership for all your hard work and staying involved in Yellowstone. And that's about it. Any questions on Yellowstone in general? No? Okay. Well, thank you, guys.
Thank you, Kelly.
Yeah.
I have one.
Yeah.
When is your meeting?
Annual meeting?
When's your annual meeting?
It's in July.
In July.
It's usually the second weekend in July.
Is that the one that's out at Coeur d'Alene?
Yes. Yeah, we had it in Cody, Wyoming a couple times, and Coeur d'Alene, the membership seems to like it, and it's closer to most of our actual members' locations. Yeah, so.
I have a question as well. You mentioned the credentialing system, are we using that here?
I'm not positive that if you guys are yet or not.
I don't think
We
so.
are not?
No.
Okay.
It was offered to us free of charge, but we didn't have the human resources to support it.
It's incredible that an insurance company is like this and returns what they do. We're very fortunate to have Yellowstone to work with. this is not normal that I've ever seen for a hospital. Where hospitals get together, create an insurance company, and then it's so careful that you're making great money, you're returning that back to the member hospitals. That's great.
There is a competing group in eastern Montana, the Montana Health Network, which I'm more familiar with, that does the same thing. I mean, it's owned by the member hospitals, and it does return also.
That's good.
As they do. But I would assume maybe a couple of those hospitals are pretty good size, of the.
In Yellowstone?
Yeah.
Yep. I think our largest is Havre, Montana.
Yeah, and if you have, some of the bigger boys playing, the one in eastern Montana has more members, but probably a lot smaller hospitals. And, you want to spread that risk, over a bigger pool, certainly, and if you have, some of the bigger size independent hospitals, that's great.
Yeah.
It's run through the hospital association too.
Yep, exactly.
Which is, it's real nice. I mean, they understand the business and you got a lot of support from Dick Brown and the folks.
Yep, MHA, and then same with Wyoming Hospital Association. So, yeah. All right, thank you all.
Kelly.
Yep.
Thank you. Thank you much.
Yeah, thanks.
All right, I'll be quick with board training. We've been trying to get scheduled with Julie to do our HIPAA training, but she's out of town today, so, well, for the next couple of weeks, but we'll come back to that next month, hopefully, that's scheduled. What I wanted to do really quickly was, I got in talking with Dick Brown over the last month or so, he sent me a list of some of the training material that they have at MHA that is available for us to use. And I'm just gonna pass the list out, and what I'd like to do is I'd like everyone to rate items of most importance so that we can bring in the training that is most critical for us right now as a board. So if you just wanna do that, and you can get it back to me. Maybe at the end, I don't wanna take too much time right this minute. He is also, volunteered to come and meet with us to help us understand what kind of resources are available to us and what MHA can do for us as well. So if that's something that we're interested in, I just need to let them know. We'd have to schedule that out. So that's all I have for training. Hey, approval of minutes. Did everyone have a chance to go through our minutes for it was last month's Finance Committee, as well as our meeting minutes from September? Are there any changes?
I'll move the minutes be approved.
Thank you, John. Okay, any further discussion? All in favor of approving our meeting minutes?
Aye.
I'm sorry, who seconded?
I did.
Thank you.
Any opposed? Okay, move on to our consent agenda. Are there any questions about our consent agenda? I'd like to kind of get moving through this. Thank you, Monte, for being so very thorough on your report.
Oh, well,
Not that everyone else isn't, you are, I just provides a lot of insight. Entertain a motion to approve those.
I would move so.
Thank you, Jim.
I'll second.
Okay, John second. Any further discussion? All in favor of approving our consent agenda?
Aye.
Any opposed? Okay. Approved. Unfinished business. Deb, NCH and EHR system update?
We continue to work with NextGen and getting things lined out with training. Our super users have all been trained. Tanai has been trained on the administrative side, which will give out permissions and passwords and that sort of thing. On Thursday, we will be doing an over-the-phone mock, sort of registering and making sure that some things go through the system. They're going back through and cleaning up missing pieces and parts, so we continue with that. Over the next couple weeks, we will be registering people, trying to move people through the system, get people used to what they need to do in the system, and then we will have a mock session around the 19th of November. I'm not sure that I have the date right, but after that, we will be pretty much closed down as far as making changes to the system. They will continue to work from the next gen side, and our go live date is December 2nd, and so we're still on target with that, and just moving along.
How many mock or dry runs or mock runs are you gonna be able to go through?
Well, when they're here for mock, we'll be
And
able to.
how long does that take?
I think it's a 2 or 3 day process. We'll be registering people or, play patients, whatever you wanna call them, from all sorts of different types of, ERs and ERs to inpatients and inpatients to observations, and we'll try and develop every scenario that we can think of and make sure that, as we register them, they get charges put and the charges are flowing and it's all flowing to the financial side, and we'll be able to create bills, and those bills look like the bills we're producing off the system now, and process them into a bad debt function and write-offs and all of those sorts of things. So pretty much all of that will be done. Some of it's starting on Thursday, so we can just kind of get a dry run of where we think we are and what are the big issues that need to be tweaked, and then the mock in mid-November will really define how much work we have or we haven't
Are we
had
ready?
to do.
Are we ready for Thursday?
Yeah,
Do we feel like we're ready?
Yeah.
To start moving with this?
I think most of the super users are out there. The biggest piece will be really getting to all of the users and getting everybody trained within the facility, and that will start happening fairly quickly.
Do we have help with that?
Well, we have super users assigned.
How many super users are there?
7, 8, I think about 8 super users from departments. Nursing has 2 super users, radiology, the billing office, all the staff in the billing office have been identified as super users. And Dina from radiology is not only doing radiology, but is also looking at helping and assisting in nursing as well. Tanai has trained in the full system, so he is a super user, more or less.
General Ledger has one.
General Ledger has one. Cliff's loving his job, but anyway, so I think the biggest thing will be getting people to get on and play in the system as time allows, and we're gonna just have to allow them the time to do that. We don't have any extra staffing at this point.
Well, yeah, I was just wondering, there's the super users. What percentage of staff that will be using it are considered super users then? And is that enough? I mean, I'm just curious, as much of a project as this is, that there's enough people to provide the support as everyone's trying to get trained and up and running.
Well, we hope that with the super users, they'll be able to train the rest of the staff and do that. It's gonna be a push to try and make sure that everybody gets trained, but probably that last couple weeks before we go live, we're just gonna have to make sure that everybody is up and ready to go, and that'll be probably our top priority for sure.
Well, that's something Larry's gonna have to focus on to some degree, I'm
Yeah.
sure.
We're all a bit nervous,
Yeah.
but
Well, you don't know until you, there's always some uncertainty
there's always uncertainty, and
until you really get in
and everybody is going through it, even the St. Pat's of the world that have a lot of people assigned to their absolutely.
If it's any consolation, I'll bet you won't have as many problems as Obama rolled out.
Let's hope not. Remains to be seen.
Yeah.
We might.
Are there any more questions for Deb? Okay, let's move on to John. You have 1 minute for mammography, and an ultrasound update.
All right, mammography is going well. We've had about 60 tests so far, and people are loving it. The room is comfortable, they like the robes, it's just going well. We have a little bit more to do in the X-ray storage area. That's getting finished up, and it should be finished up in the next 2-3 weeks. We didn't need it to start with, and so it's the last to be done. And it's our own maintenance crew is doing that. Then secondly, ultrasound, we've had 27 so far this month. We hope to break 30. Normal last year was 14. So it's making a difference having somebody there 40 hours a week. It's 4 days a week, 10-hour shifts. Then every other weekend she's also on call so she can come back and do ultrasounds. And it's going well.
Is that
It's very
paying
well.
for itself?
It
Or
is.
is it a revenue?
It's, well,
I don't know that we've done an ROI on it.
we haven't done an ROI on it, but we used to have a half day a week, and now we have 40 hours a week. And as the physicians get used to it, they'll use it more.
Well, it helps that we have good equipment now.
Yes, it does. Very good equipment.
Thank you, John.
Yeah, it's really great you have ultrasound. A lot of small facilities and communities of this size do not have access to it. It has to go inside the community, so it's really excellent that you have access to it.
Okay, ER coverage, this is an ongoing discussion.
Well, we're looking at how to cover the ER. The best way is obviously to use the community physicians we have right now, and that's, I think, going forward between Larry and Cindy. They're working on that. But we're looking at other alternatives if they don't have time to do that. And we're starting to do an ROI, and that was presented in the Finance Committee, on what it looked like to have our own hospital CR physician. And it doesn't look that good. The best thing we can do is work with the physicians that we have now, as far as cost, the profit loss basis.
On preliminary, it was like a $68,000 profit loss.
It was a
Get it that
loss,
way,
yeah, it was a
yeah.
loss, 68,000, so it's, but that'll be looked at in the next little bit, next 2 weeks, by the collaboration going on with Larry and Cindy. They're working at it.
Again, with the size of this community, I just can't imagine, John and I talked about this too, at length, and with the size of the community, I would be very surprised. I think it's really good that you ran the numbers, but I'd be really surprised if you could afford a hospitalist. And Cliff made some great points too, that, whatever comes over on the revenue side is usually a loss. I mean, it's taken away from time, that those physicians or mid-levels are spending in the clinic, for other important work that they have to do over there, so. We need to figure it out somehow between the PAs and the physician. Kirsten, I know, and the community to some extent, I mean, I'm sure has maybe some issues with PAs, but believe me, PAs in the ER, it is the standard model in a lot of facilities at PA. They must be qualified. They must be. They must provide good quality service. They must be ATLS trained, and you've got to make sure of that. But
is there training that they have to go through to be able to do ER? Is there ongoing training?
Well, the ATL, Kirsten and I talked about this last night. When she.
Because that's one of the things I've heard is concern of ER experience, or making sure that they're polished off on their ER skills that they have.
Right.
I'm really kind of appalled that this was put together without my input with regard to that.
Yeah, oh, the hospitalist thing, sure.
Sorry about that, I didn't.
You were busy on the floor.
I don't think we are ever too busy to pay attention to the quality of care
Right.
that we need
True
to
enough.
create in our facility.
True enough, true enough. Well, yeah, and the answer to the question, in terms of, the training and skills, Kristen and I sat down and visited about this last night. No, there's not, ATLS will show you that the skills are there. I mean, you have to have that, and you have to have that as a minimum, but I think it's just, especially with PAs, it's just the relationship between that physician and that PA, and the comfort level of the scope of practice of that PA. I mean, the PA has to be comfortable enough, to make sure that they, in a small community, it is extremely difficult, to get enough volume, to see, to learn on the job. You don't want that to happen. You don't want that to happen. And unfortunately, sometimes it does happen in small communities because you don't have the resources, to just make it happen over a period of time. What really needs to happen with those PAs, and I think Kirsten would agree with me, she did last night anyway, that those PAs or nurse practitioners, either way, must get into a busy ER like Community Medical Center, St. Pat's, or Billings Clinic, or someplace, and develop and see all of those crazy things that come walking through the door in an ER. It's just important, and that takes time, it takes money, it takes a lot of resources from a small rural hospital to get that, to get that provider up to the skill level that they can be comfortable in the ER.
That's right,
And it's
I'm not
all,
saying that I don't necessarily think that we should have a hospitalist. What I think we need is strong direction from a medical director.
yeah, there you go.
In our hospital. That's what we need.
The relationship between that physician, I mean, that's what I was trying to say, Kristen said it much better here. The relationship between that doc and that medical director, or just an individual doc that's supervising it and is responsible for those PAs, that they have a real, well, kind of like Cindy Sturgar and myself. I mean, you have a hand-in-glove kind of a relationship, and you trust each other. You're comfortable with what's happening in that ER in terms of the skill level, and no matter what walks through that door. And they work together with resources that are provided by the administration to make sure that those people that are covering the ER, it can be a physician in this kind of a situation too, that's not comfortable in an ER setting, has not had the right kind of training, that they do get the training, and they're well received by the community in the ER setting.
Well, and that's my biggest concern as board member. I want to make sure that we're providing a quality,
Yeah, absolutely.
Quality service to our community, and
Absolutely.
how we do that the best way.
Has there any thought been given to, we have, my understanding at the moment is that each provider is seeing on average 10 visits per day in the clinic.
Nelson.
Yeah. And is there a way to compress some of the time where fewer are seeing more patients, that some of that time then could be committed to the ER, and committed to the hospital?
You mean at Warm Springs, or?
Yeah. It kind of seems that way.
I'm sorry,
Hopefully.
I'm being very flip, I'm sorry. Don't put that in the
Were you a
minutes.
CEO?
I'm
Well, I
sorry.
think it would have to be, but at this point, I think we need to let Sarah,
Yeah,
Larry and Cindy
but
come
the-
to us with a proposal.
But the
on
idea,
what they
though,
think
of
would
being
make
able to
sense.
dedicate some of the time that's not being used for clinic visits or health center visits, that could be committed to the hospital visit, the hospitalist kind of environment. That's just a thought, you know, as you and Cindy are kind of
That
thinking
makes
things
the most
through.
sense to me.
See if we can economize a little bit with the, with that time. They may be doing, I heard you say they're doing a lot of other important things, besides seeing patients over there. But if there's a way to carve out that time productively, I would be really for that.
Yeah. I have 3 plans that I'm working on. I talked about this yesterday with the leadership team. You know, number 1 is a communication plan with the community, you know, to get around and be visible, and with the employees as well. There's a lot of work to be done there. I've only been here 2 days, not even 2 days full yet. You know, that's pretty important. The cash flow issues, we do have some cash flow issues that we're gonna work on. We had some discussion about that in the finance committee. You know, and the third one is this physician thing with the quality, you know, the whole quality issue, and the way we allocate physician time. And you know, I haven't even had a chance to sit down and talk to the medical staff, and that's really important. I mean, it's you know, we're talking about those folks, and they need to be involved with that discussion with Cindy and myself. And so I will definitely, as soon as I possibly can, bring written plans back to you with some timelines and some objectives on how we together do those things. You know, do those things.
And if you had somebody,
Those 3 plans, I will definitely, you know, bring back to you.
If you had somebody over there who was really interested in ER, you know, that was their thing. Maybe they could be devoted more to that particular function and really gain the experience.
I don't think you can afford to do that in this size community. I'm used to seeing in everyone except Livingston of my previous interim assignments and in Malta, with small rural hospitals, you know, the physician community and mid-levels have to work together, you know, to staff the ER, which is the toughest one. I mean, that's the toughest one, absolutely the toughest one. Admit inpatients, round on long-term care patients, and what's the 4th one? There's another duty in there that, well, outpatient, you know, outpatient orders and all of that activity. John, you know, am I
And
forgetting
see
something?
the clinic patients.
And clinic patients, you know, which is very important. You know, that's very time consuming, and that's a big load. I mean, that's a big load that we ask of our medical staff. It's really stressful and it's difficult to do that, to work it out. But there are ways to work it out, you know, such that, especially with a patient volume, a clinic volume of 10 per day. If you've got 10 per day, you can't afford, you know, to go out there and buy a hospitalist. I mean, it's just not. It's not feasible. It's just not feasible. We don't have that kind of dollars in the system. So, you know, I think that in terms of survivability of the hospital, that's an important issue, a really critical, important issue, you know, to work this out sooner rather than later. And, you know, I don't know what the answers are exactly. I have a few things that, you know, that we've used in the past, and, you know, John has had experience with this. He's recruited many physicians. Had a lot of dialogue with physicians, but as a team, we will get together with the physicians and we will put this plan together and get back to you with it. We definitely will. It's a tough one, and you just need to give me a little time, you know, to deal with it, along with those other little small brush fires that are, you know, that are out there. So,
Amy, may I make a
sorry,
comment?
it took too long as usual.
May I make a comment?
Go ahead.
I brought my mother in because she fell. Wade saw her in the ER. Her blood pressure was 210. He got it down to 191 and wanted to send her home. I refused. He finally admitted her. So I would sure like to see somebody in that ER with some training.
Okay, thank you. Okay, can we move on? Let's go into our finance committee report. Are there any recommendations that came out of finance committee?
Well, we spent a lot of time discussing the numbers, but everything's kind of what we should be doing. There's 64,000 operating loss over the last 3 months. And we've been hit by special expenses for lawyers and payoff of the ex-employees and et cetera that are involved in that. We were, our non-skilled and skilled beds were above this last month. Assisted living is still at 78%. I assume that that's because we can't get Medicare.
Medicaid's a problem. We've got a couple we think are coming in soon, though, and push it back to 11. We have 9 right now. We have 11 total beds, but they would go in the same room, so we still have a room left over. But we're working on that. I check at least twice a week where we're at.
And our outpatient visits are 415 versus 617, which is a big problem. We're not getting enough patients coming in. But I would make a recommendation that we okay this budget, or the
Accept the
financials.
financials.
I'd move.
Okay,
Second.
thank you, John. Any other questions or discussions?
Uh,
From the rest of the board?
I think you've got it listed as John on the transportation. We just,
Well, we can, let's finish with the financials first and then we'll go on to that.
okay.
So, all in favor of approving the financials from September?
Aye.
Any opposed? Okay, they're approved. Okay, now let's move on to the patient transportation OPEX.
Okay, we recently turned in the Jeep. It was up with its 36-month lease, and we were paying $473 a month. We passed this out.
Well, it was either turn it in or pay the lump sum $20,000 or something
Right,
like that.
right,
so-
that's right. So we have an alternative here. We can use an automobile for patient transport and long-distance trips to meetings and such by members of the staff here. And so what we've done is found an automobile, 2011 Chevy, for $13,000. It comes out to being 31.6 cents a mile, which is a great improvement over the Jeep cost, which is 55.7 cents a mile. And then if we don't do anything, it's going to cost us 56.5 cents a mile for employees to drive their own cars to transport patients and themselves. There's a liability issue with that because insurance, we're going to have to pay it anyway if there's an accident or if the car breaks down, especially if the car breaks down. And if we have control of the car and keep it up, we're going to be better off. So liability insurance alone, it kicks it over the top. But besides that, we're much lower on the costs here at 31.6 cents per mile. So I'm recommending that we purchase another automobile for use by the hospital